Hello.
Hey,
There are some keen beans already.
I know.
Lil actually said she will come and join a few minutes early, and then we'll join probably around like 6:15.
Okay, cool.
Congratulations on getting married. Don't think I've seen you
Oh,
since.
thank you. Have we not seen each other since? How's
And
things
you've
with
been
you? Oh, yeah, I know, but I mean, I feel like I'm not feeling very positive about it. I'm only ranking London, so I mean, my chances are so ridiculously slim that it feels like a wasted stress, but never mind.
No, I guess like if you've got low expectations, you'll only be surprised.
Yeah, it's true. But then like I keep being like, oh, is it really worth all this stress? But I guess it is beneficial in the long term, isn't it?
Yeah. Okay, shall I try sharing?
Yes. Do you want to give it a go? I don't know. I feel like I'm not very good at it.
Neither am I. Okay, can you see them now, or do they look like in normal mode?
One sec. I think it's loading. Yes. I can see the front screen.
Okay, fab. So,
And then there's the navigate button at the bottom. Shall I try clicking it as well?
oh yeah, can you do it?
You just clicked it, right?
Yeah. So it should be on this first page.
Does that still look okay for you? It's going.
No.
Oh
It's not
no.
going on mine. But maybe on someone else's who's not presented, maybe it would go.
Oh, if I click, I feel like this is when it went wrong last time though, isn't it? I'll click take control and then
Yes. Okay, yeah, now
now
it's
let me
presenter
try.
mode. Yeah. Okay.
Oh
Are
god.
you moving them?
Does it still look normal to you?
I'm on the first page and it looks, yeah, now it's moved and it's in like presentation mode. Like
What do you
normal,
mean by normal?
like
Okay, cool. For me.
a viewer's view.
Oh
Okay.
no, that's how it looks for me as well.
And when I put take control, it's like presenters mode with like notes on the side. Do you have that now?
Wait, you took control?
No. When I had the control at the
Yeah.
first, it was like on a presenter's view with like notes on the side.
Yeah, so
Whereas
that's what
now
mine
we've got
looks like
it
now.
together. Okay, fab.
But for you, it looks like the viewer mode, right?
Yeah, now that
Okay, perfect. So
okay.
then, and then just to check what happens when I reach the end of mine, I click stop sharing.
No.
Oh no,
When you
cancel.
don't, and then I'll put
Oh,
take
then
control.
you take control.
Now I've got it in presenter mode.
Okay,
Um,
perfect.
okay. In
Yay.
terms of like editing the slide, I've kept all the anchor statements and stuff, and I'll just skip
Yeah,
over
I
them.
actually haven't looked at the slides since the last session, so that's not ideal, is it?
I just had a quick look, and like every time I make like any change, like even like adding a letter, the whole like slide changes like the format. So I've just left things.
Yeah, it's
And
really annoying, isn't it?
then I've added Nilakshi slides at the end of ours. I will have to probably go at the end of mine if that's okay. Sorry.
No, that's fine. Yeah,
Thank you. I'll add Nilakshi now, unless there's anything else you wanna,
sounds good.
yeah, and then hey Nilakshi.
Hi,
Hey, how are you?
I'm good, thanks. I'm seeing you for a long time.
I know. Yeah, Happy New Year and all.
Oh,
Um,
Happy New Year. Yeah, I can't believe we're already 23 days into it, and I'm kind of like,
exactly. Thank you so much, by the way, for putting some slides together and talking about like IMG experiences.
thank you.
Have you met Helena before?
No, hi, I'm Nilakshi. I'm one
Hi,
of the
nice to meet
oncology
you.
grad trainees, but I think we have lost Alicia from the oncology world, I guess.
Spin. I'll do
Yeah.
spin.
Oh, okay, okay.
Um,
I didn't-
Nilakshi also does like everything. She has her fingers in many,
Oh,
many pies. And Helena's just got a grid interview for Piku.
no, when is that? Is it not
7th of
this
Feb.
week? Oh, 7th of
The
Feb. I
Pen
think they're,
ones
they're
start
doing.
tomorrow.
Okay. Oh, good
So
luck. Have you had some practice? And
A bit, yeah.
yeah.
I did it last year as well, but I wasn't successful, so
Mm.
I'm not feeling that hopeful again, but we'll see.
But you had the experience of the interview, right? So that will be really. Alicia, yeah, because obviously you've given me 3 minutes. I just want to make sure that I don't So you're going through all the
Yeah, so
stations, right?
we
As
talk about
such.
all the
Mhm.
stations.
Mhm.
It's quite tight on time in general, that's
Yeah,
why.
no, I can understand.
So we've just put your slides right at the end. So we go through like some
Yeah,
tips.
can I just look through the top tips so that I don't keep repeating? Okay, so you're talking about resources. Fine, I will not report. Revision tips. Oops. Revision tips kind of makes sense here. And then because I'll try to, because it's difficult, obviously you cannot just give IMG some completely different
Yeah.
advice, but I try to focus more on what might help them. Then I will not talk about resources. And what's your next slide? Okay, that's on the day of the exam. Oh no, I already I'm feeling stressed out reading that.
Oh no, don't.
I know every time I do the Emancipation the London Ripple one, right? And I feel like I have an exam every time I do it, like 3 times a year. And which I was
That's
telling
the thing.
Pooja, the other organizer, this is really stressful. I think we shouldn't do this anymore. But yeah, okay. And then
And that's our feedback, but actually we'll just skip past that and then go straight to your slides.
and it's okay to talk about Ripple, right? Because obviously most of my experience is from
Yeah.
I was
I
doing, and
think
they
just
cannot.
bear in mind that sometimes it's not just London people who come on this call, and we were like finding out there's also sometimes not necessarily people from the UK also joining.
Okay,
So
but
it's always
that's
really
fine. Yeah, just signposting to Ripple, and then yeah, I'll try to be very brief. So should I just join back around 6:15?
I think so. And then
But you can WhatsApp me like if you feel like.
yeah, my bit's the last section of the slides, but I'll try and like message you as well. Yeah, and that's your bits, and then I've just added our feedback. And
Thank you.
it needs to be a quick way to like restart from the beginning.
And I just wanted to ask, so we don't have that information whether we have, but your experience is we do have doctors from outside London and other countries, so that's not very helpful, right? Because my understanding is the exam is very different in overseas.
Yeah, so we're
I think
targeting.
so. Sometimes the structure is different, isn't it? Whether they have like the patient face to face for certain stations, and I don't know how they find the link either because it's only shared in the London School of Pediatrics channels. But
It must,
That's right.
and I think it's really different how many people we get, like from the few we had between like 20 to I think sometimes like 70. So it's a really big bag each time. So yeah.
I remember doing this pre-COVID face-to-face in that HE building around Russell Square. So it's a big leap from there. Are you starting at 5:30? Because I was a bit confused whether it's 6. It's not 6.
5:30, so we didn't edit that slide.
Okay, that's fine. So 6:15, I'll join in at 6:15, and if it's earlier or if you want me, just ping me on WhatsApp. Okay.
Yeah,
Thank you.
Thank you so much again, because loads of the feedback was that they want other people's experiences. So thank you.
Okay, thank you. Yeah, I'll see you there. Bye.
See you. Fab.
Apparently there's only two people waiting, but maybe more people will join at 5:30.
Yeah, sorry, it's a bit awkward, I guess, because people are going to be finishing work, whereas 6 is a much better time.
Yeah. Oh well.
Thank you.
It's fine. Yeah, I feel like so when I take control, shall I at 5:30? Shall I take control and then you let people in from the lobby?
Yeah, no, that sounds good.
Okay, cool. I need to remember to tell people, oh, it says on that slide the session is recorded. Okay, perfect. Just looking at the slides. I feel like one day I need to change the video so that it doesn't
Oh yeah, that's a good point. I don't know how I'm going to play the murmur.
Mine shows like the title of the thing. Oh well.
Okay, fine. Yeah, the grunting child.
Oh well. Hopefully it's pretty obvious that he's got respiratory distress anyway, isn't it?
Okay. Fine. Oh, it says aortic stenosis. What can you do?
Yeah. Are you still at North Mid?
Yeah, I'm on community at the moment.
Oh, how's that?
So they're a nice bunch. It's not for me, but they're
Mm.
lovely. It's as good as can be. Yeah.
Nice and chilled, yeah.
Yeah. How's Whips?
Yeah, it's fine. I really love Whips, but this last 6 months has been really bad staffing wise, so it's not been as good, and I feel quite excited to leave now.
Do you leave in March?
Yeah.
Very nice. Where are you off to?
Gosh, Piku, so that would be good.
Okay, that's nice.
Yeah. It's such a shame though how much difference it can make on a team because like for the first 12 months it was so great there and I literally loved it, and then this 6 months has honestly been like all the consultants are grumpy because there's not enough staff, then all the like the juniors are grumpy and getting stressed with the consultants, and it's like, oh my god, it's crazy how much a department can drastically change.
Especially over winter, this is like not the time you want to be short-staffed.
Yeah. Yes, it's not
Oh,
ideal.
that's
Oh well.
tough. Yeah. What can you do? Yeah.
Where are you going next? Are you at your there for 18 months?
Yeah, because I'm 80%, they've added on an extra 6 months. I'm there until March 2026.
That's a long time, isn't it?
It is a long
But
time. I think it's okay. Oh, sorry, you're going to
I
say?
you like it.
Yeah, I really like it. So I was debating whether to fast track for this bit, but actually, like, I think it will just give you more experience or give me more experience.
Yeah.
Yeah, I'm
I
still
don't
feel
think
like
that
ready to
12
start
months is enough.
You think 12 months is enough?
No, I don't. Yeah,
No.
because I also have done more because I'm 80%, and I honestly feel like I don't think being 80% really makes you that much less like clinically exposed. Because especially, I don't know about you, but like I did quite a few locums, so I probably ended up working on average almost full time.
Yeah.
I don't feel it makes that much difference, but I still very much felt like, well, I still feel like I have stuff to learn.
Yeah.
I now feel a bit less like that, but yeah, I think 12 months isn't. Oh no, but you would have had 18, wouldn't you? But yeah,
Yeah, this is the
the
end of
progress
my 12
class.
months in March, yeah. And
I
I think
think
maybe it's because of community, like I'm still doing 80% on calls and stuff, but I think because of maybe also not being there in the day,
yeah,
and I'm like still learning like how to manage like SHOs, especially on a busy shift, or like people who haven't had any experience as well.
yeah,
Yeah. So, and I feel like at the moment, I feel like an F1, like every shift is quite like mentally draining because they've been all quite busy, but also like thinking about like the logistics and supporting them. And so I feel like until that's like a little bit easier, and it's probably a good thing to have the extra months. Maybe.
yeah, I think
Yeah.
so. Yeah.
Yeah. Okay. So there's there are 3
Shall we
attendees.
let people in and go to the screen, do you reckon?
Yeah. Okay.
What should we do if like only those 3 people join? Should we just start anyway?
We've got 4. I think because like people will start. Yeah.
Okay, one more check now. Can you see me going through the slides
Yeah.
in the yeah.
Yeah. I don't know if it's helpful having the front page because it says starting at 6 p.m.
Oh crap, yeah.
Should we just move to the second slide?
Yeah, or I could quickly edit it on the
I think then we have to reshare it all.
oh, do we?
And I feel like we've got it working.
Yes, let's just go to the second one. Yeah.
Yeah. Okay. All right. I'm gonna mute and let people in.
Okay. Hi everyone, welcome to ACER Clinical. We'll just give everyone a couple more minutes to join, and then I'll return. Hi everyone, welcome. So I think a few people are still trickling in, but we'll get going for the sake of time. If any of you could pop your cameras on, that would be really great, because at the moment I'm just looking at a sea of blank screens. So I'm just going to talk about what we're going to outline in this course today. So we'll be having a look at the general structure of the exam. We're going to look at how the exam's marked, and we'll also think about the scenario types. We've also got Alicia here with us. So I'm Helena, I'm a Peds Reg at WIPS, and we've got Alicia, who's a Peds Reg from North Mid, who'll be taking over for the second half. We've also then got Nilakshi joining to have a quick chat about kind of the perspective of an IMG. So just in terms of the current face-to-face exam that you guys will be doing, so it's face-to-face with some patients, and that means there's children in your clinical station, but role players in all of the other stations, so the development, the history, and the communication stations. I think this is the same way it's been running for a while now, and is the same structure as how it was when Alicia and I both did it, so feel free to ask any questions that you want to ask. And just to reiterate that the aim of this exam is to assess that you're the standard of the newly appointed SD4. So you don't have to know everything, you just need to be showing that you're safe and that you can escalate appropriately. I just wanted to, mention before we move on to the next slide, the meeting is recorded. So if anyone isn't happy with that, please just let us know. So here is a website that's really useful. Hopefully you might have had a look at it already, but it's got some guidance, lots of resources. It's got a few previous videos of mock stations and some important questions. So take a look if you haven't had a look already. And the timings on the day itself, so the exam is about 2.5 hours long, so it's quite a long exam and it's really tiring. But you'll be able to get through it, and there's breaks between each station, and there's also a couple of break stations as well. So you've got 9-minute stations in the clinical station, the communication, and the video station. And you've got 4 clinical, 2 communication, 2 video, and then there's your 2 longer stations, 22 minutes, development and history taking. So in each station, you should have a knock on the door 3 minutes before the end of the station. And this is a really important reminder to you that this is your time to start tying up and thinking about the final parts of your answer. You're going to have a 4-minute break between each station, which is time to move from the physical room to the next room, and also hopefully a little bit of time to sit down, read any information that they've given you beforehand, and make a few notes if you want to. Lots of people always ask questions about PPE and what to do. Generally, I would recommend that you ask your centre on the day what they expect. For mine, for example, they had said, don't worry about putting gloves on, but you needed to gel your hands between each patient. But they'll make that very clear to you on the day. So thinking about the marking, how does that work? So there's 5 different domains. Not each domain is tested in every station, and we'll have a very quick look at which ones are tested and which, and this can help you sort of focus what key points you need to be hitting in which stations. So you're scored between 0 and 2, below standard, borderline, or meet standard. The pass mark is 62 out of 82, but there is an additional domain of professional conduct. So even if you did score above 62, there's a chance that they might be concerned, for example, that you've shown a patient safety issue, and they might still be able to fail you. So just be very careful that you're kind of being professional and not saying anything really silly. So this is a little image of the different domains that's scored in each station. It's a bit confusing to have a look at. You might want to have a look at it in more detail, but it essentially shows you kind of the most important areas that you need to be hitting for each one. So for example, if you can see in all of the communication ones, you need to be managing your concerns and agreeing the next steps. That's why those 3 minutes are really important, because if you haven't got to the part of managing the next steps, you've lost a third of the marks that's available for that station. So just take a bit of a look at that in your own time if you haven't already. And I won't talk about all of these in great depth because they're all available on the RCPCH website. And it's quite self-explanatory, but what you should probably focus on is the blue box on the left, which shows what you need to be doing to meet the standard and get that score of 2. So if you have a quick look, it's quite self-explanatory. So asks relevant key questions in the history taking, sensitively gathers appropriate information and explores main problems. Whereas below standard, it's asking questions which are not particularly relevant, haven't really gathered a particular good amount of information, and just a bit all over the place, essentially, is what they're saying there. So important to be nice and structured, clear, and hitting all of the relevant key points in the clinical situation. This again is more of them for all of the different domains. And again, I would encourage you to take a look in your own time. It's similar themes throughout the whole thing. So active listening, allowing the other's opportunity to speak, being confident in the communication part. That's a really key thing. So you really need to practice so that you're confident. If you come across really worried, then they're going to score you down a bit. You can see there in the below standard one is poor body language and non-verbal skills. So yeah, just really practice coming across strong and confident. So first of all, we'll talk a little bit about the communication stations. So again, as a reminder, they want you to be the standard of a newly appointed ST4, not a consultant or anything like that. So your aim is to communicate appropriate, factually correct information in an effective way and within the emotional context of the clinical setting. The role player in your communication scenarios could be a parent, it could be a teenager, it could be another health professional, or even a member of the public, but I think that one's a little bit more rare. And it has in the past come up to be a telephone conversation as well. So just think about how you might change your initial kind of spiel of your communication situation. Behind, they won't take part in the scenario, they won't ask you any questions or be part of the role play. And again, like we said before, this is a 9-minute station and you're going to get a warning bell 3 minutes before the end. And you really need to use that time to wrap up, agree the next steps as we looked at that marking domain. So what might they ask you in the communication station? This is the 6 broad areas of communication situation that you could get. So it might be information giving, so telling a parent about a diagnosis. It could be bad news, so please explain some results that might have a poor prognosis, taking consent for example, an LP, an incident like telling a parent about a drug error, could be a difficult ethical situation, so talking to a teenager who doesn't want to have blood tests, or it could be education, so talking to a medical student about something that they want to learn a little bit more about. So try and prepare for each of those different scenarios. So what do you want to do in this scenario? It's really important to set the scene. So if you just remember back to that information grid, I read out that they wanted you to deal with the situation in an emotionally sensitive manner. That's really important for the communications session. If you have, for example, breaking bad news, you really need to set the scene and make it clear that you're going to take them to a nice quiet room. You might want to say that you're going to get rid of your bleep and ask your colleague to hold it, and you might want to bring, for example, a nursing colleague with them, or suggest that they bring a family member along with them. Next, once you set the scene, you're gonna tell the examiner what's going to happen next. So you're gonna say what the bulk of the conversation is going to be before you actually do it. You're then going to do the bulk of the conversation, and then you're going to check that the role player has understood what you've said. And sometimes people are a little bit uncertain about what phrases to use to say this, worrying that you might be implying that someone hasn't understood. Someone once told me a really nice phrase, which I quite liked and used myself, which was, "Can you summarize what I've told you so that I know I've explained it correctly?" And once you've done that, you want to ask whether they have any questions to ask. And then hopefully by this point might be about the time of the 3-minute bell. And you need to then agree a plan going forward, what's going to happen next. So for example, if you've broken some bad news, you might want to say that you're going to come back at a later point if they think of any more questions. You might want to say you can bring your consultant if that's felt necessary. And then you might want to bring them any information leaflets or signpost them to relevant websites or support groups, for example. So thinking of an example station, we've got Lydia, who is 5 years old, and she was admitted to the ward after presenting with tiredness and bruising. Her initial blood film shows blasts, and your task is to discuss the results with her parents. If you could perhaps pop in the chat or pop your speaker on, whichever you prefer, and just let us know, how would you approach this scenario? Just give you guys a few minutes to pop your ideas down. Any ideas from anyone? Yeah, so Adiba, you've said this is breaking bad news. Yep, and so how are you going to go about that? Tell me the important things in the scenario. What would you want to say to the parent? Yeah, really good. So James has said, start by asking them what they know already. Ask if they understand why we were doing the bloods, then lead into blood malignancy. Yeah, that's perfect. That's a really, really good suggestion, James. It's so important to check the understanding of what the parent knows before you approach the scenario. It might be that the parent is already really worried about malignancy and they're going to come out and say, this is what I'm really worried about. And actually that makes it really easy for you to broach that and say, I'm really sorry, but unfortunately it is malignancy. If the parent has no idea that we're thinking about something sinister, you obviously need to maybe approach it a tiny bit more sensitively. And so we've got getting it. Yep, so perfect. So Varnika has said we're going to get the setting right. So privacy, parent room on the ward, bring the oncology nurse and the colleague. Yep, fabulous. So if you've got an oncology nurse, if you're in a tertiary hospital, get their perception of what's happened so far and their ideas, concern, expectations. Yeah, perfect. And you've got warning shot and further information with chunk and checking. Summarizing and signposting and follow up. Yeah, perfect. So chunk and checking is really, really important. And I was always told make sure that you're not the one giving. You just need to. You can't be giving all the information to the parent, and that's what Varnika means by chunking and checking. If you guys haven't heard of that before, give a chunk of information. Wait for the parent to take that in and check their understanding. Yeah, signposting, perfect. And so you guys have mentioned that you're gonna have to break the news. What kind of wording might you use to tell them that it is malignancy? If anyone could pop their thoughts in the chat. Yeah, so James has said use the word cancer to unclear otherwise. Yeah, exactly. Yeah, I think so. Some people might think about saying malignancy, some people might think about saying cancer. I think I agree, James, that cancer is much clearer. Another thing that people commonly do and might not feel confident to say it's malignancy or cancer and skirt around it a little bit and say, oh, we're quite worried it's something sinister. I think it's really, really really important to just come out with it. Yeah, and so Varnika has said address the elephant in the room. Perfect. Blood cancer. Yeah, you don't want to be skirting around it. You just need to get it out there. Of course, make sure you've given a bit of a warning shot first. But yeah, just be clear, this is what it is. And then really important, just give the person a chance. Then just silence and let them take it all in. The role player might cry, they might get very upset, but you just need to give them a little bit of time to process that and make sure that pause might feel really uncomfortable for you, but just make sure you give an adequate pause before you start talking at them again. Ideally, you can wait for them to start talking. That would be perfect. Okay, great. Yeah, so that was some really good ideas that you guys had there. So just thinking about the anchor statements for the communication station, this basically outlines the domains that they're looking for. So it's information sharing. Important thing is that you're giving relevant information and you're giving accurate information. So don't say stuff that's not true. And if you're not sure, don't say it. Just say, I'm not 100% sure of the full details and I'll need to check that for you. You need to have a good rapport with the patient and a good communication style. And again, here it's saying that you need to be nice and confident. So be polite and professional and make sure that you're giving them time to talk and ask questions as well. And that's the next domain is verbal and listening communication skills. So not only are you just talking at them, but you're really giving them the chance to come back to you as well. And finally, managing concerns and agreeing next steps. So yeah, I think one of you, I can't remember who it was, but someone mentioned that we were going to signpost and follow up. So your next steps for this one, does anyone want to pop in the chat what you might include in your final 3 minutes for the next steps? or any resources you might want to signpost to. No, okay, we'll move on, and people can pop in the chat in the meantime. But you've covered some of them already. You might want to agree that you're going to come back and answer any more questions, because it's very, very overwhelming news, and I'm sure that the parent will probably want to take a bit of time, and they might not be able to think about all the questions there and then. So you're going to offer to come back. You might want to offer to get them a cup of tea. You might want to offer to phone their family member, for example, their partner. You could offer to do that if they find it too difficult. And then you're going to offer them some resources, perhaps websites, an information leaflet if you have. Yeah, so someone's put NHS site on blood cancer leaflet and clinic follow-up. Yeah, so clinic follow-up is a good, I mean, hopefully they're probably going to have some more soon intervention than clinic follow-up. But yeah, absolutely. Any diagnosis that you're giving, that's a really good thing to think about. So next we're going to think about the video station. So these are another one to make clinical observation. It gives signs which can't otherwise easily be assessed in the clinical station. So more acute things, for example. And then as well as identifying the problem, they want you to talk about your management and your clinical reasoning of why you're doing what you're doing. So as we said, it's a 9-minute station. You're going to have 3 minutes to watch the video. The videos are kind of between about 30 seconds to 1 minute, and you can keep playing them as long as you want. So in mine, they gave me a laptop, a set of headphones, and I could just keep watching the video until I was satisfied. You've then got 6 minutes to answer the questions, and you'll get a warning 3 minutes before the end. So this one, we sort of just covered these points, but these are the anchor statements, the domains that they're looking for. So they want you to identify the clinical signs. They want you to reason why you're coming up with your diagnosis based upon that. And then they want you to talk about your management planning. What are you going to do next? So what might you get in the video? You might get something acute, like respiratory distress or a seizure. You might get strange examination signs, all kind of standard ones as well. It can be quite varied. So you might get an abnormal gait, you might get a skin rash. Also a possibility is something like safeguarding, so don't ever forget that one. So in terms of identifying clinical signs, when you're given your video, you need to look at all of the clues in the video. So I think it's really good idea to comment on everything that you can see in the video, and also anything important that you can't see. So for example, if it's a patient who appears to be having a seizure, but you can only see the top half of their body, it would be important to comment on the fact that you can't see the bottom half. If they give you headphones by the computer, put them on, because there's probably audio clues. And if you've got, for example, a monitor with a SATS reading, look at the SATS reading. Next, once you've looked at your video, you're gonna describe what you've seen, and then you're gonna say, well, okay, so what are my differential diagnoses? Think broadly, but also think what's the most likely, and don't forget safeguarding. So you're going to want to list all of your differentials. Probably about 3 is a normal number to list, unless you think that there are a significant number more, which could be very plausible. And I think you should say them in order and say them why they're in that order. So this is my top differential, and this is because, and give your reasons, because to get those points for the clinical reasoning, you really need to tell them why you're thinking what you're thinking. They can't guess. And then management planning is your next step. So once you've told them your differentials, you're going to talk about what you're going to do next. So you're going to talk about any investigations, and I like to structure this into bedside, bloods, imaging, and other or special tests. And then you're going to talk about the management. So are you going to admit them? And if you are, where are you going to admit them to? Do they need to go to PICU? Do they need to go to HDU? Can they go to the general peds ward? You're going to talk about your medical management, and you're going to talk about who you might need to liaise with. So do you need to tell your consultant about them? And do you need to talk about any other specialties about them? So we have an example here. I'm just going to play the clip. If you've got your sound on, turn it up so that you can hear. And I want you to pop into the chat what you can see. So in as much detail as you can. What are your top 3 differentials and why? What investigations you'd like to do and what would your management be? Also, if someone wishes to have a go at talking it out as you would in the exam, feel free to pop your hand up. Yep, so we've got in the chat, some people are saying recessions, grunting, nasal flaring, worker breathing, prolonged expiratory phase. I want a much bigger description of what you can see. You can see much more than just recessions, grunting, and nasal flaring, can't you? What else can you see in the picture? Yep, so someone's written respiratory distress, probes, and a peg tube. I can't personally see a peg. Yeah, perfect. So someone's written would like to look at the monitor since it's beeping. Yep, we've got nasal flaring, intercostal recessions. Yep, so the descriptions are getting more and more detailed, which is great. This is as much detail as you need to be saying. So we've got approximately 6-month-old child able to sit in hospital, attached to ECG leads and heard beeping monitor, DSAT, query DSATs, grunting and subcostal recessions. Yes, great. That's a really good description. You've hit all of the important points there, and that's really good. One tiny comment is that when I was doing my exam, someone once told me don't estimate the age. I think you can estimate perhaps within a range, but don't say an exact range. I know you have said approx, but maybe just say somewhere perhaps between 6 months and 12 months. Flush face, no diagnosis. Great, yeah. So if I was going to describe this video, I would personally say very similar to Varnika's one. I'd say I can see a child who is sat up in the bed. There is some obvious respiratory distress. He's grunting, he has nasal flaring, he has intercostal and subcostal recessions. I can see some ECG leads attached to his body, but unfortunately I can't see any readings on the trace. I can see the trace beeping, and I wonder if that's because he has abnormal observations. So then next, if you guys could tell me what's your top 3 differentials, and if you could say why next to each one. Why is that your top one? Why is the second one less likely? Okay, so Deepak says croup, epiglottitis, foreign body tracheitis. Can you tell me why you've got those as your differentials? Yeah, good. So we're getting a little bit more description. So bronchiolitis because of age, prolonged expiratory phase, pneumonia. We've also got bronchiolitis, lower respiratory tract infection, cardiac. Varnika says bronchiolitis due to worker breathing in this age group, viral induced wheeze with worker breathing, but need to auscultate the chest and get a full history, and query Lurty. And you've written, would like to know whether they are febrile and chest X-ray. Good, yeah. So I think it's really important to justify why you've put your differentials in that order. So for me personally, I would say bronchiolitis is my top differential in light of the age in a child with respiratory distress. My second and third differentials would probably be a LERTI, and I would also consider viral induced wheeze, but I think that would be much less likely in his age. Cardiac is another good suggestion from someone a bit more broadly. I would also be thinking about other systems such as cardiac. Yeah, perfect. So a couple of people are saying also need to rule out cardiac cause. Yep. Up at the top, we've got some suggestions: croup, epiglottitis, foreign body. I think that will be a bit lower down in my differentials because the sound that I can hear in this video is grunting rather than stridor. But if you heard stridor, that would be a really good list of differentials. So you've put a couple of someone's put they'd like a chest X-ray. Could everyone pop in there what investigations they'd like and try and pop these into bedside, bloods and imaging or other? Okay, so far we've got some bedside tests, oxygen sats, no investigations. Amigan Aho, can you tell me why you've put do not disturb the child? And we've got blood gas, chest X-ray, full set of obs. Yeah, great. So this is a really good one. Bedside, full set of obs and a blood gas. Simple bloods including CRP, MCNS and chest X-ray. What else have we got? A respiratory virus panel. Yep, fantastic. So if you're thinking about bronchiolitis, you might be thinking about kind of cohorting patients. Lots of things coming up. So we've got complex query echo if concerned RE cardiac. Yep, so that's definitely a good suggestion. I think I wouldn't go in it with my first set of suggestions, but definitely if you're saying if there was anything that made me worried about cardiac, yep, chest X-ray depending upon findings, ECG if SVT. Okay, great. Yeah, so some really good suggestions. So I think what you're going to say is going to be guided a bit by what you're going for with your top differential. If it was me, I'd be saying that my top differential is bronchiolitis. So I'd say in terms of bedside tests, I would like to do a full set of observations, including a heart rate, a blood pressure, and a SATs and a temperature. In terms of bloods, I would like to do a blood gas. I wouldn't necessarily start doing a full set of bloods or culture unless I thought that this was complicated by a significant LERTI or the child appeared septic or unwell. In terms of imaging, I might consider a chest X-ray if there's a significant deterioration, but I would also probably comment that I wouldn't do this in every child I was suspecting with bronchiolitis. And other tests, so someone has mentioned a viral swab, which is perfect. And then thinking a little bit more broadly, if we are concerned that actually the diagnosis could be more cardiac, for example, thinking about an ECG or an echo. So great. And then, if we're going to go with the diagnosis being bronchiolitis, can you guys tell me what your management of this patient would be? And just going back up, I think someone had put, do not disturb the child. It's good. Yeah, we should always not upset the child more than they need to be anyway. That's most important if there's upper airway problems, so croup or something, for example, then 100%, yeah, you want to do absolute minimum intervention to make anything that would make the child more angry, just don't do it. Yep, great. So Dean has written oxygen therapy, consider high flow if marked worker breathing and oxygen requirement. And you might also be having a look at your gas results. And then if further deterioration, consider intubation and ventilation. Yeah, great. So you've shown that you know all of the kind of potential steps in the management. I suppose another potential step that you could mention is CPAP, but yeah, Optiflow is what we pretty much always start first. So that's definitely the safest thing to mention. Perfect. Yep. So we've got supportive things, oxygen feeding antipyretic. Yeah, so how are you guys going to feed the baby? Can you pop your suggestions in? So someone's put NG feeds. Yeah, any other considerations that you might take, alternative options to consider? Yeah, great. And so we've got admit, discuss with consultant, assure they are in HDU or general ward with HDU bed and appropriate nursing 1-to-1. Perfect. Oxygen if needed, CPAP if apneas, Optiflow and feeding support, IV fluids and nil by mouth, or NG feeds, continuous boluses. Yeah, perfect. So loads of really great suggestions there. So absolutely, the first thing that I would mention in this is thinking about, before you go directly into medical management, you're definitely going to admit this child, aren't you? So you're going to say, I would like to admit this child. They look quite unwell. I would also like to escalate to my consultant. And yep, very appropriate to say that you would want them in HDU, definitely if you're going to be starting Optiflow or CPAP with 1-to-1 nursing. So generally, yeah, we've got the suggestions of Optiflow and CPAP. I think definitely safest, just to say you'd go with Optiflow for now. 100% CPAP if apneas is good, and if very significant apneas, of course, intubation and ventilation. Feeding wise, we've said we've got some suggestions: NG tube, IV fluids. I probably personally would say that I would start with NG feeds with a low threshold to switch to IV fluids if the patient clinically deteriorates. Yeah, perfect. That's what someone's just said. NG tube, if severe worker breathing hold feeds, IV fluids. Yep, perfect. And you might want to start at smaller, more frequent feeds to begin with through the NG feed, like 2 hourly. Perfect. Yep. So I think you guys have covered everything, which is great. So next I will hand over to Alicia, who's going to talk about the clinical stations.
Thanks, Helena. So now we'll talk about the clinical stations. So the clinical stations are basically there to assess that you can undertake a structured and systematic clinical examination and be able to pick up clear key findings and interpret them. It's basically what you do normally on a day-to-day basis. And just to remember, the standard that they're assessing you is at a newly appointed SD4. There are 4 clinical stations in total, and you've got 9 minutes for each station. You've got 6 minutes to do your examination and then 3 minutes for your discussion. And these are the anchor statements that are associated with the clinical stations, and you can see it all on the RCPCH website, so I won't talk through them. And basically you have different things that could be asked. It could be, the examiner will give you a very clear vignette and introduction of what they want you to do, and they might tell you to do a full system examination. For example, can you examine this child's cardiovascular system? They might ask you to do something very specific. Please, can you palpate the child's precordium and listen to the heart? Or they might tell you to do an observation. Just by standing here, can you tell me everything about this child from what you observe? And usually this is dependent on how the child is when you're there. For example, in one of my clinical stations, the child had just fallen asleep. So it went from, would you examine this child's respiratory system, to can you actually just listen to the chest? And on the RCPCH website, they've got this key document called clinical examination technique, and I suggest you all have a look at it. And basically it's this PDF that goes through all the different examinations and what they would expect from you. So it's super useful. And what it entails, so one of the things it says is all the different areas that could be covered, and as you can see, it's a long list of things and systems and potentially even some imaging, but ignore so it doesn't seem too overwhelming. It's, again, everything that you'd be doing normally anyway in your jobs. So yeah, so they're expecting you to be organized in your approach, but also like adapt to the child in front of you, because we know that children might get bored or upset, and then you have to just sort of change your approach. And again, this is what you do normally at work anyway. And then pick up your signs and when you're practicing, practice discussing signs and putting them all together and figuring out how to interpret them, and then practice how you present your findings afterwards and find your own structure. One way is to start with your main findings and listing both your positive and negative findings, and then coming up with your list of differentials. And then when you're examining, you might actually be able to predict some of the questions that the examiner might then ask you. So here is an example. So this is Emma, and she's come in for her annual review, and the examiner's asked you to do a cardiovascular examination. So just to start off with, if in the chat, can you type what is part of your standard cardiovascular system? And this is what you hear when you listen to a chest. Give you some moments for you to type. Does anyone want to type anything into the chat or unmute yourself? Oh, amazing. So yeah, so looking at the hands for if there's any clubbing, cyanosis. If there's any pallor, remembering to look at the mouth, looking at whether they've got dental caries, the JVP, palpating the chest, listening to heart sounds. Is there a murmur and does it radiate? Remembering to listen at the lungs, and if there's any peripheral edema or hepatomegaly. Remembering to think what they're like from the end of the bed assessment. And Yasin Lanka's written like, remember to introduce yourself and get your consent and hand wash, and remembering to do your general examination. Someone's asked what slide one, slide 30. Hopefully you can all see it. If you can't, then please put it on the chat. And yes, and whether there's any scars as well. So exactly. So I think for some of us, it's been a long time since we've done a full systematic exam. It might not have been, it might have been like in med school, we've actually done the full thing, because in day-to-day life, we're adapting for children. So remember, when you are practicing, to go through the whole thing. So introducing yourself, getting consent, washing your hands, doing the general inspection, doing your peripheral examination by looking at the hands, checking your pulses, looking at the face, looking for any pallor, looking exactly when you're then looking at the chest, see if you can see any scars, palpate it, and then auscultate. Remember to listen to your all four areas. Are there any murmurs? And if you do hear a murmur, think about what maneuvers you can do to hear the murmur better, and whether the murmur radiates anywhere. And then, as you said, listen to the lung bases and palpate for hepatomegaly and peripheral edema. And then sometimes an examiner might ask you, how would you complete your examination? Or after you examine the child, you may suggest it yourself if you haven't been able to do everything you would want to do in an ideal scenario. So if you want to put in the chat things that you would do to complete your exam. And yet someone's already written they would ask for a beat, blood pressure. Feeling the femorals, inspecting for Yeah, hepatomegaly. So exactly, if you haven't been able to, didn't run out of time and not able to palpate for hepatomegaly, by all means say that in an ideal world you would have palpated for it. Plot weight on a growth chart, fall in blood pressures, SATs, looking for JVP. Again, I think JVP, it will depend on the age of the child. On a young child, it might be quite difficult to assess for that. So yeah, so taking your full history, doing an observation, including your blood pressure and oxygen sats, thinking about whether you want to do a respiratory examination, and palpating femorals, and then like someone said, actually saying you would plot their weight on a growth chart as well, on an age appropriate growth chart. So based on what you can see and hear, how would you present your findings? What is your differential diagnosis? Danny, I'm not sure if you're trying to answer the question. It's not really crackly, so I don't know if you want to put it in the chat. Yes, you're not supposed to be able to see the video because it tells you what it is, but you should be able to hear it.
Oh, sorry, Alicia, I realised what the person's asking. Where can they hear the murmur?
No, oh, I see. So you would be able to hear it loudest on the right second intercostal space. Okay, so for time's sake, I will move on, but I think so. Deepak has and Dalib both said aortic stenosis, and it's an ejection systolic murmur. So again, just sort of think about how you would present. Exactly, this is what someone's just put, that they've examined Emma, who's a 7-year-old girl. This person has correctly assumed that they have a very bubbly personality with cocktail chatter. And then you would say that you've heard an ejection systolic murmur that's loudest in the right second intercostal space, and most likely in keeping with aortic stenosis. And then actually from what you could see from the picture is actually you would comment on the facial features, which is in the diagram there, and say these are characteristic, along with hearing aortic stenosis with an underlying diagnosis of Williams. And so then, now that you know that, what investigations would you do for Emma? And think about what Helen said about what structure to use as well. Yeah, they're all coming in. So if we're using the structure, so bedside test would be your ECG. Thinking about doing bloods, including a bone profile. So someone mentioned making sure you're checking calcium because hypercalcemia is associated with Williams syndrome. Imaging is an echo to characterize the murmur further. And then for your special tests, I would discuss with your seniors whether you need to send genetic tests. As I said, is her annual review. She's probably already got a genetic diagnosis. And usually as a junior, as a resident doctor, you probably wouldn't be making that call yourself whether to send genetics, and would always discuss with your consultant first. Okay, so next we'll talk about the developmental station. I'm just going to talk a bit quickly for time's sake. So the developmental station is assessing whether you can take a focused developmental history and gather information and know how to assess a child's development using appropriate toys and equipment. That all the children should have a development age of 5 years, of less than 5 years, and for the exam, I think you're not having children still. So it's a 22-minute station. You have 9 minutes to take a history with a role player, and there's 3 minutes warning before the end of those 9 minutes. And then the role player will leave the room, and then you've got 10 minutes with the examiner to summarize the salient points from the history and then describe a developmental assessment, and then summarize the assessment, and then you've got 3 minutes at the end to then discuss your further management with the examiner. Again, these are the anchor statements that go with the station. I'm not going to read them out because it's all on the Ask2PCH website. And then what is expected. So remember to gather your information from the history. You'll be asked to assess at least 1 or 2 of the developmental domains. So that's gross motor, fine motor, speech and language, and social communication skills. And for which one they're telling you to assess, you can't ask about that one in the history. And then they may give you some sort of clue. So in my developmental station, they gave me a photo of a child that had dysmorphic features, and it's just a little reminder that it's not the aim of the station for you to know what that syndrome is, and you won't get any like marks taken off if you just don't know what the underlying syndrome is, because the aim is for you to assess the development, not to pick up the signs. And when you're thinking about your management plans, just remember to be holistic and think about the social, educational, financial needs, and if any home adaptations are needed. So as part of the history, it is very tight for time. So really do practice this because you need to be speedy and efficient. And what I like to do is at the start, with the role player, I would introduce myself and set the agenda and ask them if there was anything they were worried about, concerned about, or what they expected. So then that way I can address their concerns. And then also, because I've set the agenda, I can then just crack on with asking the questions in the history. So you want to know about like the birth history, the past medical history, and specifically I would ask about seizures, their growth, their hearing, their vision. And a good way to pick up if they do have other health needs is asking if they're known to any healthcare teams, because then you might actually hear, oh, they're known to speech and language. Remembering to ask about their drug history, and in particular, are they up to date with their vaccines? Is there any family history of developmental delay? As part of your social history, think about asking about consanguinity, what impact this is having on the family, and again, remember to think holistically. What's their house situation like? If they're at school, do they have an educational healthcare plan? And then when you're asking about the development side, remember to ask about regression specifically. And like I said, you can't ask about the domain that you're about to assess, but you can ask about all the other domains. And as part of your practice, think about ways that you can quickly assess the other domains. On the website, they have this, they tell you all the equipment that you will have to do your assessment. And because you're not actually doing the assessment, in my exam, they had a photo of this with the list. And this is quite useful because then you can practice how you would describe your developmental assessment using the objects in the photo. And then, yeah, so the assessment, it is a bit weird describing what you're going to do. So do practice it and remember your basics as well. So remember that you're going to introduce yourself to the child. And when you're doing the assessment with the examiner, you're supposed to be talking it through with them, but I've heard of some people's experiences as the examiner roles playing as a child, so don't get put off by that and just adapt to how the examiner is doing it. And then just be very specific about what you're doing And so when I say I'm going to introduce myself, then I will ask, like, what does the child do when I walk in the room and introduce myself? Do they hear me? Do they make eye contact? Or actually, are they just engrossed with the toy that they're playing? And then say that you would like look around the room, and then they might say, the exam might tell you, oh, actually, there's a wheelchair in the room. And as I said before, practice having a structure of how you would assess each of the developmental domains. And also think about asking about the quality of the task, because rather than just saying, I would see if they can walk and assess their gait, then ask, like, actually, how did they walk? Because it might be that they did walk, but actually they're a bit wobbly or ataxic on their feet. And in general, when you're doing the assessment, you start with the easy tasks that you think the child would be able to do, and then progressively go to the harder ones until you can find their limit. And again, try and be as positive as possible. So, for example, rather than saying they can't draw a square or they can't do something, say today they were not able to demonstrate drawing a square, because you have to remember that this is not like a perfect setting for an assessment, and in an ideal world you would do repeat observations. And then the RCPCH website has actually a lot of useful things for the developmental assessment, because they are aware that this is a bit weird. So they've got an example video, so then that will help you know what the baseline that they're looking for. And they've also got some tips on how to describe the examination. So like I said, consider what you're looking for and make sure you're specific. So when you're saying I'm assessing for dysmorphism, rather than just saying that, you would say, like, I would look at the position of the eyes, nose, and mouth in relation to each other as I assess for dysmorphism. Thinking about so the examiner will also give you either dependent clues or universal clues. And universal cues are things that might be given at the start of the station or they're in the room with you. Like I said, they might have a wheelchair there, or they might have photos like I had. And then dependent cues are things that the examiner will tell you only if you ask something specifically. For example, if you said, I would see if they could build a tower, the examiner might just say, yes, they built a tower. But if you said, I would see how tall the tower was, then the examiner would say the tower is 2 blocks. The examiner may interrupt you with additional cues to help you, so don't let it put you off. For preparing for the station, this is generally what most people use and is sufficient to pass the station. You can find it on the London School of Paediatrics MRCPCH website, and it's the table for each domain. So if you memorise that, you'll probably be fine for the station. Because of time, I won't do this one in the chat, but an example of that you might be asked is, David is a 3-year-old and his parents are concerned about his ability to run around and play like the other children. You've been asked to take a full history and assess his gross and fine motor domains. From the history, you elicited that his speech and language and social skills are appropriate for his age. And then, just because we don't have time, so in your own time, you can think about how you might approach the developmental assessment and describe it. And the last station is the history station. This is again one of the longer stations, so it's 22 minutes, and you've got 13 minutes with a role player who might be a parent or it might be an adolescent patient, and you get a warning at 9 minutes, and then a warning at 13 minutes, and then the role player will leave at 13 minutes, and then you've got 9 minutes for a discussion with the examiner and a 3 minutes warning before the end of the station. The aim of this is to see that you can take a focused history and pick up the key issues, summarise it for the examiner, and be able to formulate an appropriate management plan. This might either be for a new problem that they're presenting with, for example, headaches, or something very specific in a child with an established diagnosis, for example, weight loss in a diabetic child. There's no examination as part of this, but you might be given some extra information, for example, investigation results. And what is expected. So again, it's basically what you're doing every day as part of your work. So be your usual self, be friendly, professional, interested and supportive to the role player. Remember to take a focused history and gather enough information to determine what is going on. And remember all the other bits as part of your history. So your birth history, past medical history, drug history, family history, social history. And adapt what you're doing to the needs of the role player as well, and how you're asking your questions. I think what is quite nice is also remembering to explore the role players' like ideas, concerns, their expectations and feelings as well. And that's a nice way you can adapt your history to them. And if you've got a teenager, think about doing a heads assessment, which, if you don't know, you can Google it. It's a holistic way to take a social history. And in general, just think about good communication techniques. So asking clear questions, using a mixture of open and closed questions. Try to avoid using jargon, or if you do, then explain it. And then use common communication techniques. So chunking and checking, which we mentioned earlier, and invite the role player to ask you questions as well. And then some tips for the discussion with the examiner. So think about and practice how you present, so you're not just summarizing the whole history again. One way that some people like to present is using the SBAR technique, saying what the situation is, the background of the patient, your sort of assessments, or your key pickups, and your recommendations going forward. From the history, you might be able to anticipate some of your examiner's questions, and you may be able to start thinking about what your differentials may be and investigations. And then when they ask you about your investigations, remember that structure of what bedside tests, bloods, imaging, and then other special tests you might want to do. And for your management, think about, are they unwell or not? Do you need to liaise with other teams? And then your general management as well. And then just some general tips for the exam. So for revision, try and practice under exam conditions so that you get used to it. And on the RCPCH website, they've got mark schemes that you can then use as well. Find a partner or a small group of people also sitting the exam that you find give you useful feedback and are quite honest with you as well. Ask people to examine you or do teaching. That can be other like registrars or even consultants. Try and even to like ask consultants that you might be intimidated by, because again, that will make you feel more relaxed in the exam should you have an examiner that's a bit more intimidating. Remember also to see real children, and you can do that by going to your wards, go to specific clinics. For example, I went to a cardio clinic that I found was really useful at hearing different types of murmurs. And think about whether you could go to your local tertiary hospital to see maybe some children who may have additional signs. See if you can use your study leave and maximize it. And I think the video station is like the hardest to prepare for, so sometimes it gets neglected. So just remember that it exists and you will be asked to do it, and think about emergencies, acute things that they may not be able to examine you otherwise. Resources, there's loads of resources out there, and it can be quite overwhelming. In general, just pick one or two things that work for you and stick with it. Like I said, there's loads of information on the exam on the RCPCH website. The second website is the London School of Paediatrics revision website, which is, it's a bit old, but it does have that developmental table that's super useful. There's also a corresponding YouTube channel that had a few recorded revision lectures on there that I personally found quite helpful. YouTube in general has lots of examples of different signs and gaits. And there's also podcasts as well, such as there's Gosh Has Got a Revision podcast, there's Peds Pods, Dragon Bites, which you can listen on your commute, and patient leaflets, I think, are really useful as well. And Gosh has got some, as well as other organisations. And reading them just also helps you think about what resources are out there that you can signpost people to, but also gives you a way of explaining sometimes quite complex conditions in simple terms. Some general exam tips. So you'll get an email with what you need to bring, but in general, bring your ID, bring the admission document that's sent to you. Try and enjoy it and relax, as easy as it is to say, because basically you are being watched doing what you do every day. So just be yourself, and I'm sure you'll be fine. Everyone there wants you to pass. They do give you paper for each station, so you can take notes, but I think after the station is over, you have to then discard it. Because sometimes it's hard to remember everything during the exam. And if there's a station that you have messed up on, or you feel that you've messed up on, just try your best to forget about it and move on to the next station, because you can still pass the exam overall, even if you do mess up a station. And if you think something's happened on the day that is unfair, just raise it on the same day to the invigilators, because then they can actually do something about it and try and address it. Results are usually given 6 weeks after the exam. And when you're given your results, you're then also sent a copy of your mark schemes, which your examiners are filled in, and sometimes they can contain really useful feedback and advice should you have to take the exam again. This is our feedback form, but actually we are joined by Neelakshi, who is a London School of Paediatrics trainee and is also an international medical graduate, and is going to talk about her experience as well.
Thanks, Alicia. I'll be very brief. I know we're overrunning. I think Alicia has very beautifully summarized what we need to do, and particularly the top tips around the exam. So I am currently an oncology grad trainee at Great Ormond Street, and I've been I'm an international medical graduate. I took the exam back. I had to take it twice, once in 2019, 2020, pre-COVID times. And I found certain things very challenging, and I thought a lot of it was because of my training from being outside of the UK. And so this is kind of my passion, try to bring together what things that had been helpful. And obviously I'm not sure how many of you are IMG doctors on this call, but you might be aware of the fact that, which is very obvious, or if you look on the Royal College website, that IMG doctors are less likely to do well in the exam compared to UK graduates. But the college is addressing these issues of differential attainment, and they're doing a lot of work around it. But I think the most important thing to remember that you're all brilliant doctors, you're all amazing pediatricians, and you've come a long way. At least the first thing you've done is got on a flight and came to the UK. So I think that's a big step forward, and I would just see this exam as another step that I'm sure all of you will be successful with. Are the slides moving? Or do one of you need to move?
If you take control, you should be able to move the slides. If not, just say next slide and I'll do it.
I'm not sure. Next slide. Is it showing like a cartoon of the Worrying Worries that?
Yeah.
I was going through, and I still think about this because I'm also one of the co-organizers on the London Ripple exam prep course, which again I'm guessing some of you are on the course as well. So just briefly, I think one of the things that we just have to be mindful about is some of us do not have the experience of an OSCE style of exam because of different exam patterns back in our home country. So I think this session had been really helpful with Alicia talking through what the exam is going to look like, and I think it's really important for you to, the basic minimum need to read is all the guidance that's on the Royal College website. Being on the Ripple course for the last teaching on it for the last 3-4 years, the feedback I always get from IMG doctors is the most important worry is the communication, because as we all say, English is not our first language, and probably we have been used to communication, particularly with patients and families in our native languages. But just taking again a step back and reflecting on your work on the shop floor, we do have a very diverse patient group, and a lot of times English is not the first language for our families as well. And we do very well with communication, right? It's not that we are terrible at it. And there's other things other than language which are really important. And all of you deliver care with compassion and empathy. So do not forget that. I do understand there's certain things that I found helpful at that time is like picking on small phrases which sounds well, and I think the best way to gain that is by practicing with other doctors. And once you're practicing as a team, I think you'll be picking up on small phrases which you might think, oh, that sounded really well. Why don't I use that when I'm doing a communication or around breaking bad news? Please find a study buddy, because the other problem with IMG doctors, if you're on a non-training post, is you kind of feel a bit isolated. But again, Ripple, again, get through to this London School of Pediatrics to find other doctors who are practicing together. That helped me, because I was on the Evelina job at the time, and we had 5 doctors on the shop floor who were taking the exam. So that really worked for me. Another thing, I think some IMG doctors, you're coming in for some specific subspecialty jobs, which can be a bit of a hindrance, because this exam is a general pediatric focused exam and not even much of neonates either. So if you're on a subspecialty job, maybe this is a time just to think through what are the opportunities, like Alicia said, taking a study leave to go somewhere in a clinic, like a cardiology clinic, to listen to some murmurs, or even going to A&E and seeing some patients. If your donor hospital doesn't have a general pediatric setup, just find ways of trying see if you can practice. I can understand with COVID it's difficult, but if you can practice in other settings. And a little bit top tips around, I think we don't get into this vortex about this exam is like a big hurdle in your career progression, because the portfolio pathways are a little relaxed now. They're not very insistent on the exam. But I would say the exam was a great opportunity to understand myself, to understand my practice, how it's going to look like in the UK. And I still use a lot of those structures and stuff I learned in the exam to see my patients every day. And please do look after yourself. I think this is really important. Again, I understand you're away from your family and friends networks. Look after yourself when you're preparing for the exams, and reach out to any of us if you are struggling. If you move the slide, please. Yes, again, these top tips are very much reflective of what we've just heard. Patient information leaflets. I think I read more of the patient information leaflets than I read a book. That helped me with my communication. Then I'm picking up a language that is not jargon and understandable for patients and families, particularly with young person, because again, that could be a struggle. A lot of our home countries have a pediatric age cutoff of 12 years. Observe, volunteer, and practice. I think all these sessions, and particularly the Ripple sessions, and if you're doing local practice, don't be that person who's just standing in the corner and observing others. Be that person you want to go ahead and putting yourself in front of others. The stress of exam, that really helped me at the time. So practice is what my top tip would be. And my next slide, I think I have some contact details. I think I have my email address on my next slide. I understand this is really brief, so if you want to contact me, just drop me an email. Can you just move the slide, please, Alicia?
I think it's on your last slide with your
Yeah,
email.
so that's my email. So please feel free to contact me if you have any more questions, and also a Ripple course, which is running currently. But if you, I hope not, but if you have to come back ever, so just please feel free to contact Ripple as well. And good luck for the exam. That's mostly me. Sorry.
Thank you so
Thank you
much,
so much.
Alexi. That was really helpful. Thank you. If anyone else in the audience has got any other questions that they want to ask any of us, then please feel free. You can either pop your speaker on or pop it in the chat.
Thank you so much. This was really useful.
Thank you so much.
Thank you.
You're welcome.
Thank you.
Perfect.
Okay, cool. I feel like that was successful. That was only an hour and 10 minutes. That must be our
Yeah.
shortest one.
I think that was good, not doing the anchor statements, and it was really nice of Nicola to talk at the end.
Yeah, that was really good, I think.
And if we recorded it, we can then use it. Maybe I'll ask her if she's happy if we use it in future ones.
Perfect. Cool. I hope you enjoy your dinner plans then. We can make a date for the next one, maybe closer to the time of the next one, do you reckon?
Yeah. So I feel like this has gone on the back burner a little bit.
I feel it's so hard to remember it, and then every single time, both like we leave it like until like a few weeks before, don't we? And then I'm like, oh my god, why do we leave it so late? Maybe I'll just like suggest some dates later today, and then at least we have a bit of a head start.
Yeah. They've just
Do you
sent
have your
our
rota though?
They just sent it. I've not actually looked at it.
Oh,
so
fine. We'll leave it for a bit then if you haven't even looked at it yet.
No, but send some dates and I can have a look.
Okay, cool.
Yeah, amazing. Well, all the best for your interview. And,
Thanks.
okay.
I'll see you next time.
Bye.